Is everybody else on the line already, or?
Yep, we have a total of 22 people with us, so that's it.
Hello, this is Attiyyah. I'm here.
Okay, great, Attiyyah, thanks. All right, so whenever you guys are ready, just tell me to start.
Good afternoon.
I'll start talking to you.
No problem. Good afternoon, everyone. Thank you so much for joining us for the chronic disease series for the Black and Brown communities. Today's topic is breast cancer prevention and early detection. My name is Harold Shukla. I'm an outreach coordinator for Cancer Support Community Central New Jersey. And as most of you may not know, we are located in Bedminster. We provide professionally led support services, educational workshops, as well as health and wellness workshops to anyone that is cancer, that just the individual going through the diagnosis, but including families, children, as well as caregivers. And anyone that comes to our organization, there's no cost. 89% of every dollar that's donated goes towards the programs and cancer support services. And so I will leave my information in the chat if anybody needs to reach out to me. If you know of anyone that is in need of any cancer support services, please let us know. We have social workers that could provide over the phone if need be. And please mute yourself just so we don't hear any background noises. And I will hand it over to Dr. Lue.
Okay, well, thank you very much, everyone. I'm very excited to be here today with Attiyyah Muhammad-Callaway from the Breast Center at Steeplechase. My name is, as Harold just said, my name is Dr. Deborah Lue. I'm the director of the Santa Fe U.S. Breast Care Program at the Steeplechase Cancer Center at Robert Wood Johnson University Hospital in Somerset. I work directly with Attiyyah. We take care of breast patients at our breast center. We see close to 10,000 women at the breast center each year for mammograms as well as treatment. We're here to talk today about breast cancer prevention and early detection, particularly as it pertains to the Black and Hispanic community of women. Okay, specifically, we'd like to review how breast cancer affects different ethnicities of women. We'd like to discuss the observed and the reported differences in breast cancer biology or personality of each breast cancer as it affects women of different ethnicities. We'd like to discuss the observed and reported differences in breast cancer outcome in the diverse populations. And finally, Attiyyah and I'd like to have a conversation with you all on what we can do to help minimize racial disparities in breast cancer. Attiyyah and I would like to hear what your concerns are and what your backgrounds are, each of you with breast cancer or working with people or having people in the family with breast cancer. Okay, so what do we know about breast cancer amongst women of all ethnicities? Breast cancer does not discriminate. It is still the most commonly diagnosed cancer in all U.S. women after skin cancer. In 2019, the American Cancer Society reported over 268,000 new cases of breast cancer. And although the rate of breast cancer is not increasing as sharply as it was back in the 1980s and the 1990s, the rate of breast cancer is still going up in the United States by about 3.3% per year. In other words, there are slightly more women affected with breast cancer in 2019 than there were in 2018, and there will be more affected in 2020 than there were in 2019. So overall, breast cancer death rate continues to decline in the US. However, it is still the second leading cause of all cancer death in women after lung cancer. And so we'll go on to the next slide. Okay, so as with white women, Black women get breast cancer more commonly than any other type of cancer. There are 33,840 new cases of breast cancer in Black women in the United States in 2019. That was out of about 104,000 cases of cancer for all Black women in 2019. So in other words, of all the cancers that women had in 2019, about 1/3 of them were breast cancer. Other cancers were lung, colorectal, pancreas, thyroid, but the majority of them, 1/3 of them were breast cancer. Okay, so what do we know now?
So Dr. Lue?
Yeah.
We're going to launch the PrePoll.
Oh, okay. Why don't you go ahead and do that now then first?
Yeah, I'm going to go ahead and launch the poll for you guys. And if you could answer the questions based on your knowledge so far, go for it.
Before I go much further.
That's fine. I just launched it, so everyone should be able to see it. So the first question is, according to the American Cancer Society, Black females who get breast cancer are more likely to die from their cancer than non-Black females. And we're still waiting for people to answer, so I'll let you know.
Okay, that sounds good.
I don't know if you could see it on your end at all.
I can see the poll questions. I can't see the answers. I'd really like to hear what the community thinks. Or
Yeah, so I'll tell you the numbers. We still have a few people answering, so just give me a second. It tells me the numbers, so that's how I know.
Mhm.
If you haven't answered, please do. And you know, this is just to test your knowledge, so don't hesitate. Okay, so we had 16 people answered true to the first question. We still have more. Yep, most of the people know the answer to that. First one was true. And then the second question was, Black women get a less aggressive subtype of breast cancer more frequently than non-Black females. And we have 24% of people, just 4 participants, answered true. And 13, which is 76%, answer false.
Don't answer the questions right now because we're going to pull them at the end, correct?
Yep, so I'm just gonna
Just give us the data, right? And then we'll go through the data at the end.
what I have, yep. And then the third one is regular mammogram screening reduces a woman's risk of dying from breast cancer by 10%. We had 15 people answer true, and then 2 people answered false. So I'm gonna end the poll now, and then you can continue.
Okie dokie. So, okay, so what is the rate of breast cancer in white females as compared to Black females? So let's see if this is going to work for me. And it's not. Okay, well, essentially my screen was supposed to say that 1 in 8 white females are eligible to get breast cancer, end up getting breast cancer in their lifetime. That's about 12% risk of getting breast cancer. And Black females have a very slightly lower rate at 13%, but it's roughly about the same. That being said, actually, you know what? I'm not getting my screen share. Maybe that's why. Oops. Okay. Okay. Sorry. I wasn't sharing the screen. So there I am again. Sorry. So this, so the rate of breast cancer in white females is about 13%. And in Black females, it's about 12% over their lifetime. Okay. That being said, even though the incidence of breast cancer is about the same between Black and white females, there's a huge gap with regard to death rate and the type of breast cancer that, that Black females get and white females get. Okay, so although the death rate is decreasing across the entire population of women as a whole, the death rate is still 40% higher in Black females than it is in their non-Black counterparts. Okay, and this is despite a similar incidence rate. Hold on, I am not. Okay, as you can see, I've highlighted here, this is the death rate, okay, for Black females as compared to a death rate. Can you guys see my pointer?
Mm-hmm.
Okay, as compared to 20 per 100,000 females who are non-Black. So that adds up to a 40% higher risk of dying. And as you can see across the other ethnicities, the death rate is a little bit lower. So for Black females, that death rate is significantly high. And if we look at Black females in their younger years, it's even more pronounced. For Black women under 50 years of age, the death rate actually doubles the rate of white females, okay, according to the American Cancer Society SEER database. Okay, so it's really significant. Let's see if I can get to the next screen. There seems to be a little delay here.
Sometimes it happens.
Okay, let me just see. Sorry, I apologize. Okay, maybe part of, wow, I'm missing the actual numbers on the screen.
I wonder if it keeps tapping or clicking. I don't know if it works.
All right, let me try something. Okay. Okay. So this slide is meant to show you that part of the reason maybe for the higher mortality or the higher death rate in Black women may be related to the type and to the stage of breast cancer that Black females get in the United States. Research has shown us that not all breast cancers are the same. In fact, the more we learn, we're finding out that each breast cancer is individualized, nuanced by the genetic code of the breast cancer as much as each human is nuanced by their own genetic code. So how do we assess the personality of a cancer? We look at its biology. And specifically, we're looking at certain receptors. HR stands for hormone receptors, and HER2/neu stands for another receptor. So there's really 3 receptors, 2 hormones and 1 HER2/neu that we look on most cancers to assess the personality of a certain type of cancer. And as you can see, the most aggressive subtype of breast cancers is this dark gray one called a triple negative breast cancer. And as I've highlighted here, Black females have a 21% likelihood of having that subtype or that personality type of breast cancer, as compared to 10% in the non-Black community and other lower, similar almost to the white community in the Hispanic, Asian and American Indian communities. Okay, so literally double the rate of triple negative breast cancer. So what does that mean? That means Black women, when they get breast cancer, they more frequently than any other ethnicity get a triple negative or more aggressive subtype of cancer. Additionally, Black females, when they have breast cancer, it's usually detected at a later stage than it is for other ethnicities. And that's what I've highlighted in here. And interestingly, this is also similar. Their rate is similar to the Hispanic community. So the Blacks and Hispanic community get, when we pick up their breast cancer in 2019, 2020 here, they're more likely to have a more advanced stage than their non-white, than their non-Black and non-Hispanic counterparts. You can see that rate is 33%, 32%, as opposed to 26% and a little lower in some of the other ethnicities. What does that mean? That means that most of the time we're picking up a cancer in a Black female or a Hispanic female when you can feel it, okay? When it's actually a palpable mass, not when it's been, not when it's something that we detect on a mammogram. Okay, this gives us a potential opportunity for improving survival in the Black and Hispanic community. More to come on that later. Okay. Okay, so what should you be doing? Okay, sorry. Until we have a cure, the answer is going to be prevention and early detection. I cannot emphasize this enough. Okay, so the first thing, do not skip the mammogram. Mammograms save lives, okay? Mammograms reduce the mortality from breast cancer by about 60%, okay? You see the greatest amount of lives saved in the 40 to 50-year-olds. And I know there's a lot of screening guidelines that are out there, some from the United States Preventive Task Force, which recommends, annual screening after 50. American Cancer Society actually recommends that women after age 40 be given the opportunity to have screening mammograms. Now, as you can see, the death rate for Black females is highest, okay, between the ages of 40 and 50. So I am encouraging women, Black women and Hispanic females to get mammograms starting age 40. Everyone should get mammograms starting age 40, but particularly that community of women, because the death rate is so high under 50, okay? And the type of cancer that they get is so aggressive. That subpopulation of patients is not the group of patients who should wait till later in their lives to start their screening mammograms, okay? So everyone, we recommend at Steeplechase get annual screening mammograms beginning at age 40. Do not stop, do not skip years, okay, until you plan to die within the next 5 years, okay? So that means for the rest of your life, okay, for the most part, okay? I can't emphasize enough, mammograms save lives, okay? So let me just give you a little brief background on the history of mammography. As you can see on the screen, what a mammogram in 1969 would look like and what a digital mammogram in 2013 looked like. You see the quality difference improved significantly. Even then, back in 1969, mammograms were still saving lives. As you can see, all this white tissue has to do a lot with the density of the breast and the quality of the image. The quality of the digital image in 2013 has improved significantly. As you can see, we can see the tissue density. So this kind of lighter gray area, just to give you guys some just technique issues here, is fat. This white area that you can see outlined through most of this tissue is the actual glandular tissue of the breast, and we'll start about this. We'll get some more information on this later. Okay, the 2D mammos came around in the 1990s, which is this, the 2D, and the 3D mammos came around about 5 years ago. And I'm going to go some more into the 3D and why it's useful in a little bit. But what's the difference between a 2D and a 3D mammo? Okay, for each mammogram that you get 2 pictures of each side. You get, we squeeze from top to bottom, and Attiyyah will go into some talk about this later, but we squeeze from top to bottom for one view, and then we squeeze sideways on your breast for a second view. Okay, so the picture just goes straight through the whole breast. That's a 2D mammo. So imagine now I have a loaf of bread. If I just take a picture of that loaf of bread from one end to the other end, that's a 2D mammo. Now a 3D mammo is, imagine I took that loaf of bread and I sliced it into 15 slices and I took a picture of each slice. That's a 3D mammo. Okay, and that's the difference in quality, that we can look at each slice. So 3D mammos improve our ability to see through dense tissue, and I'll go through that a little bit more later as well. But that's pretty much the difference between a 2D mammo and a 3D mammo. The 2D mammo is a picture like you see here, but it's the entire breast, all the layers put together. A 3D mammo is if I slice that breast up into little slices and took an image of each slice, and it allows us to look at each part of the breast individually. Okay. So if you've already had your first mammo, and you know, I'm curious, I guess we can't really tell who, they can't tell me like this how many of them have had a mammo already, or no?
If I were to add it in a poll, I probably would know. But if
Or if they can just respond in the chat, just so we can get an idea.
you can write in a chat if you're, or you can unmute yourself and obviously say, raise your hand, whatever the case may be. But
Yeah, thanks. I just want an idea of how many women have already had a mammo.
if you say you have, at least in the past year, and I can count it up, if you can write it in the chat. So far I have 2 yeses, 1 no. For the most part, we're getting yeses.
Okay, good. So if you've already had your first mammogram, you may have been told that you have dense breasts. Okay, so this next section here is on breast density. So what does breast density mean? Okay, breast density is the amount of glandular tissue. I'll show down here. Density is just the amount of glandular tissue you have to the amount of fat that you have in your breast. So in this picture, this picture, the glandular tissue is this purple lobular tissue that makes the milk, and these yellow ducts that carry the milk to the nipple. Okay, this is the glandular tissue, and then the fat is this tissue that surrounds all of the lobules and the ducts. Okay, so the glandular tissue is actually the feeding portion of the breast. The ducts make the milk. The glands make the milk. The ducts carry the milk to the nipple. So the evolutionary purpose of the breast was to make it available to feed, okay? So the fatty tissue just supports all that glandular tissue. A dense breast is one that has more of these lobes and ducts than a non-dense breast, okay? So why do I care? It's just a fraction. Density is just the amount of glandular tissue I have to fat. Why do I care how dense my breasts are? Because almost all breast cancers, over 99% of them, start in the glandular tissue. Okay, they either start in the lobe or they start in one of these ducts that carry the milk to the nipple. If you have a cancer that starts in the lobe, it's called a lobular cancer. If you have a cancer that starts in the duct, it's called a ductal cancer. But again, I repeat, almost all breast cancer starts in the glandular tissue. So if you have more glandular tissue, than a woman your age, all other factors being equal except your density, you have a higher risk of getting breast cancer than a woman who doesn't have it. So if this woman here with this ratio of glandular tissue to fat would be called average. Let's just call this one average. Somebody who has dense breasts would have this, okay? They'd have more lobules and more ducts. See, as you can see, it starts to make the breast very busy in here. So on a mammogram, this looks very white, okay? And it makes it harder to see. Let's see if I have a picture. Okay, so this is what density, all those glandular tissue, this is what it looks like on a mammogram. On one end here, you have very fatty breasts. So this woman has very few ducts and lobes compared to fat. She has a lot more fat in her breast. Whereas the woman over here would be someone we call extremely dense. And you can see how white the breast is, right? And that's because she has all that glandular tissue. All that glandular tissue, all this purple, and it looks very white on the mammogram. Okay, and why does that matter? That matters because the abnormalities that we look for when we screen on a mammogram, we look for a mass density or nodule, we look for microcalcifications, and we look for asymmetry between the breasts. All three of those things show up as white. So if your background is very white, you can see that it's like looking for a snowball in a snowstorm. Very hard to find, okay? And you can see clearly. So women who have heterogeneously dense breasts or extremely dense breasts have a higher risk of getting cancer, particularly women who have extremely dense breasts. Only 10% of all women have extremely dense breasts. But if you have heterogeneous or extremely dense breasts on your mammograms, you're gonna be told that you have dense breasts, okay? And dense breast women have an increased risk for getting breast cancer, okay? This is what the density looks like. Right. So just basic facts about density. Increased density decreases the sensitivity of the mammogram. You can see why it does that, because it makes it harder for us to read the mammogram, because something that's white on white is not going to be as easily seen. Dense breasts are mostly governed by genetics. That's one thing I wanted to highlight here. A lot of women come into my office and ask me, okay, so what can they do to decrease the density of their breasts? And I say there's actually very little that you can do. Most of your density comes from your genes. I mean, your mother probably had dense breasts before you and your grandmother before her. The only thing that changes the density of your breast a little is exogenous hormones. So women who are taking hormones, that will actually plump up or proliferate the tissue in her if women are taking exogenous hormones, I often tell them if they want to decrease their density, they can stop their hormones, okay? In general, your breast density decreases as you get older, but up to 1/3 of women can actually retain their breast density even after menopause, okay? Okay, so let's get back a little bit to the difference between the 2D and the 3D mammo with the woman with density. So we just said that, women who've got dense breasts, their background tissue shows up as very white. So this mass, for example, this is a mass on a 2D mammo, and this is actually breast cancer. As you can see it on a 2D mammo, but it's a lot more subtle. It's much harder to see. This is the actual 3D slice that cancer showed up on. And as you can see, it's much more prominent. You can see the lesion. So what is this about this mass that's very suspicious? The irregular shape, okay? Lesions that are very irregular, we get more suspicious about. You see this mass also looks like it's got these sunbursts, these rays coming out of it, okay? We call this spiculations. So sometimes you might see the term spiculated mass, okay? This is what they're referring to, a mass that looks like it's almost being pulled, from the corners, that these bands are almost pulling them. So with the irregular shape and the spiculations are something that look very ominous from us who look at mammograms frequently. But you can see the difference between a 3D and a 2D mammogram at finding this same mass, okay? All right, so at this point, I'm gonna turn this over to Attiyyah for just a second here. I'll let her discuss some of these most frequently asked questions. Go to it, Attiyyah.
Okay, can you all hear me?
Yes.
Okay, so thank you, Dr. Lue. for the introduction. So again, like Dr. Lue said in the beginning, my name is Attiyyah. I am the procedure and mammography nurse here at the Sanofi Breast Care Center here at Steeplechase at Robert Wood Johnson in Somerset. I meet patients every day. They ask these questions every day about what to expect during your mammogram. So we'll go through a little bit about that. So what you're seeing here on Dr. Lue's screen is a mammogram machine. So some of you that have had a mammogram, you're probably familiar with it, and some that may have not had a mammogram yet, but this is the mammogram machine. The breast is placed right between those two plates, and that machine has the capability to rotate on its side. Not only, like Dr. Lue said, if you imagine a slice of bread, the breast is placed between those two plates, top to bottom, and then it also has the ability to rotate and compress the breast from side to side for different imaging purposes. So on to the frequently asked questions. So how do I schedule? What you can do is you can give us a call at the Sanofi US Breast Care Center here at Steeplechase, and we have schedulers that will schedule you. How long does it take? A mammogram usually takes about maybe 20 minutes. You'll be here for the procedure. If it's a screening mammogram, you do not have to wait for a radiologist or the doctor that reads the mammogram that same day, since we're talking about screening. So you can come have your mammogram and you can go on about your day. Can I wear deodorant? We do not advise that patients wear any perfumes, deodorants, or lotions, because we do not want that area to be clogged with these chemicals or materials to place onto the plates, because they have particles that can show up on the mammogram pictures, and we don't want those to be confused with, like Dr. Lue said before, we also look on mammograms for what are called microcalcifications. These can be falsely picked up as those particles can be falsely picked up as microcalcifications, and that's what we don't want. And we don't want anything to block off the imaging so that it can be read accurately. Does a mammogram hurt? So the breast is placed in compression. Most patients do not complain about any type of pain or discomfort. It is a weird feeling or sensation because the breast is compressed. However, like Dr. Lue said previously, the importance of compressing you, we always say that we compress because we care. We want to make sure that we're able to view through all of that density correctly to make sure that nothing is being missed. And how much pressure. So based off of the thickness or the size of the breast will depend on how much will have to be compressed. If he has a larger breast or a smaller breast, sometimes it's a little bit harder to get a smaller breast into that plate so that the technologists and radiologists can get a good picture. However, most patients, majority of my patients do not complain about any discomfort.
Thanks. Okay, so hang on one second. Let me just go back. Whoops. I just want to answer the last question about what's the difference between a screening mammogram and a diagnostic mammogram. For those of you who've had a mammogram before, for the screening mammogram, we take 2 pictures of each breast. We squeeze from the side for one view and then from head down for the other. That gives us 2 views of each breast. So it's 4 films you get. When you get a diagnostic mammogram, you get, what we do is we usually will magnify one area, so you'll get extra views that magnify a certain portion of the breast that might look suspicious from the screen. And sometimes we do an ultrasound as well at the same time. If there's something that we do see on the mammogram, we will at the same time do an ultrasound. So that's the difference between a screening mammogram and a diagnostic mammogram. If you get a screening mammogram and there is an abnormality seen, a lot of times you'll be called back. Oops, sorry. You'll be called back. Now I've lost my talk. Hold on one second. Or extra imaging. Okay, so that's the difference between a screen and diagnostic. All right, so we're going back to what should you be doing. I think we've covered it pretty much about mammograms. So mammograms are preventative. They stop you from getting excuse me, mammograms are part of early detection. They will not prevent you from getting breast cancer, okay? They are the cornerstone, though, of early detection, which means getting the cancer when it's most treatable and least lethal, okay? And so I emphasize again that this is particularly important for Black females under the age of 50, where breast cancer is its most deadly amongst all women, okay? So now let's go on to what you can do to prevent breast cancer from ever happening. The U.S. Preventative Task Force and the American Institute for Cancer Research have estimated that approximately one-third of all breast cancers are avoidable. So what does that mean? Just think about it. There are 268,000 new cases of breast cancer in the United States each year. At least in 2019 there was. Almost 90,000 of them could have been prevented from ever happening at all. So that's pretty powerful. So what should you be doing to stop breast cancer from happening? Okay, to understand what you should do, we got to look at what your risk factors are. Okay, so on the top here, these are all risk factors. Some of them are controllable. That means that they're in your, that you have some influence over them, and some of them are uncontrollable. So looking at the uncontrollable ones, the two biggest risk factors for getting breast cancer are being a woman, okay, and getting older. Okay, those are the first two, and those are beyond your level of control. Okay, if all women, I tell my patients, oh, all of us live to be 150, we'd all have some sort of low-lying level of breast cancer. That's just what happens as the cells age and they get older. It's similar to men and prostate cancer. If all men live to be 150 years old, they also all have some low-lying level of prostate cancer. Increases with age. Okay, so there are other things on the top here that are beyond your level of control. Genetics, having an early period, that puts you, that means girls who start having their periods before the age of 12 have a little bit higher risk of getting breast cancer than women who start having their periods later, between 12 and 14. And girls who actually start after 14 have a little bit lower risk than the average female for getting breast cancer. Family history, particularly that of a first-degree relative, increases your risk of getting breast cancer. Breast density increases your risk for getting breast cancer. Having a late menopause increases your risk of getting breast cancer. That means a menopause after the age of 55, okay? Radiation prior treatment. For Hodgkin's lymphoma, that's a big one. Sometimes thyroid area will increase your risk for getting breast cancer. But look on the bottom here. These are all factors that you have some control over that do also increase your risk for getting breast cancer. Never having had children increases your risk for getting breast cancer. Having a child after the age of 30 increases your risk of getting breast cancer, and after the age of 35 significantly increases your risk for getting for having breast cancer. Breastfeeding has been found to be protective. So I encourage all women, if possible, go ahead and breastfeed. It's good for baby and it's good for mom, okay? And some women ask me, well, how long? For anything that's over 6 weeks has been shown to give women a breast cancer risk benefit, decreases the risk. And what it has to do with maturing out the breast cells. Women are all born with breast buds. That breast bud develops when you go through puberty and fully develops when you start breastfeeding, okay? And that's part of the reason why nulliparity, or never having had children at all, increases your risk for having breast cancer as well. You're born with a type 1 and type 2 breast bud. That cell stays there as a type 2 after puberty. Doesn't go into developing a type 3 breast cell or a type 4 breast cell until you go through pregnancy. A type 3 breast cell develops after you go through pregnancy, and a type 4 breast cell is a fully lactating breast cell, so that doesn't happen unless you breastfeed. Type 2 breast cells, for whatever reason, and we're not sure what that is, are more susceptible to getting breast cancer than type 3s and type 4s. So a woman who's never had a child has a type 2 breast bud, and it will stay there her whole life until she goes through a pregnancy, okay, and through breastfeeding. I don't know, this is just a little piece of archaic history. Breast cancer back in the 1500s used to be called a cancer of nuns. Physicians back in the 1500s noticed that nuns used to get breast cancer more frequently than other women. They didn't know why, but they just called it a disease of nuns. And that, we think nowadays, has something to do with their nulliparity, okay, that they had a higher risk of getting breast cancer. Okay. Hormone replacement therapy, that means using hormones after menopause, has been shown to have an increased risk of breast cancer. And these last ones are actually pretty significant. Actually represents not just risk factors, but increasing risk factors. So the ones that are actually controllable, that have the most impact on your risk, are your weight, the amount of exercise you do, irrespective of your weight. Okay, so even if you are not overweight, how much exercise you do actually has an effect on whether you get breast cancer or not, and your diet. Okay, and these are things that I want to stress. These are things you can do to prevent breast cancer. So what do we recommend? We recommend a plant-based diet. What does that mean? That means at least 3 to 5 servings of fruits and vegetables per day. Okay, and what is the serving size? Everyone should stick out their fist. This is the size of a serving size. Okay, and when you look on your plate, you should have that many veggies. Okay, and that many fruits. Okay, 3 to 5 per day. Each one of those fists is considered one serving. Okay. Every ethnicity has their own version. Everyone talks to me about, oh, it's a Mediterranean diet. Yes, the Mediterranean diet is one type of plant-based diet that has been well studied, but each ethnicity has their own version of a plant-based diet. Okay, so I encourage you to just start thinking about that. Okay, so focus on a plant-based diet. And how does that help? What that does, plants decrease the amount of inflammation in your body and in your inflammation means that cells are kind of, think of a cell that's kind of that's beleaguered, that's kind of beaten up, okay? That's kind of over and over been prodded and prodded. That's what an inflamed cell looks like, been poked and prodded. These processed foods have that effect on your cells. They poke and prod your cells. These chemicals, they poke and prod your cells. So the more your cells are poked and prodded, the more likely one day one of them is likely to go bad. Okay, and that cell that's gone bad is either going to be picked up by your immune system and kicked out, okay, or it's going to go on to divide and divide and divide until it becomes a cancer. And that's how diet over the long term affects your risks for getting breast cancer. So amount of obesity, BMI, the target BMI. And what is BMI? Body mass index. It's an indicator of how much fat you've got in your body. The ideal body mass index for women is between 18 and 24.9, or 18 and 25, pretty much. Okay, that's where you want your BMI to be. There are lots of BMI calculators to take into account your height and your weight. That's how we calculate BMI. Okay, it's the amount of weight that you have per height that you've got in your body. So I encourage all of you to go out there, find your BMI, and look for it to be between 18 and 25. If it's over 25, and for most of us it is, you've got some work to do, okay? And we can work at getting that down, okay? Exercise. Exercise irrespective of obesity. That means that even if you're not overweight, you should still be getting at least 75 to 150 minutes of exercise per week, okay? That sounds kind of onerous when you start saying that, but if you think about it, it's about 20 to 30 minutes a day. It's very little. You know, I tell my patients, you know, do it first thing in the morning until it becomes a habit. And that way you know you're done for the day. But that's really what I want exercise and diet to be worked into your lives as. It's something that's a habit. That's not something you have to think about. It's just something you do automatically, like brushing your teeth. I mean, most of us brush our teeth because we don't want dental caries, and we've seen people who don't brush their teeth over time. It doesn't look very pretty, okay? But we don't get up in the morning and brush our teeth anymore because we're worried about dental caries and what it might look like. It's just a habit. So even though the initial motivation was that, if you keep doing that 21 days, 30 days, a month, 2 months, I want these lifestyle things to be worked into your routines so that they become a habit. They're not something you have to think about anymore. And yes, in the beginning, it may sound kind of difficult. And if you fall off the track, I don't want any of you to stop and say, oh, I can't do this anymore. I just want you to keep on trying, because let me tell you, over time, it's going to work. Look at your GPS. What happens if you follow the GPS and then you take a turn too early? Oops. You know, does your GPS blow up? No. Your GPS just reroutes you back onto track. So I want you to think of lifestyle changes as things that, like a GPS. Don't get discouraged. Keep at it. It will pay off. I promise you. Okay? And find some sort of accountability or motivator to start in the beginning, like the toothpaste. You know, we encourage our kids to do it because guess what? It's something they don't think about when they're adult anymore. They've been doing it so long. It's just something you do. And at some point, if you don't brush your teeth for 2 or 3 days, you actually feel pretty bad. I mean, and that's what it will be too with these lifestyle changes. If you don't eat right and you don't exercise for 3 or 4 days after it's become a habit in your life, you're going to feel lousy, and it's going to prompt you to go back and do it some more. So I encourage you just to find the habit. And that is the hardest part in the beginning, but all of us can get there. And once we do, the payoffs will be huge, because the inflammation in your body will go down. You will feel it. I have patients tell you over and over who tell me this over and over. It feels better. You feel better. Okay. And the inflammation goes down, your risk for cancer goes down, but also guess what? Your risk for heart disease and stroke also goes down, because those diseases are also affected by chronic inflammation. Okay, so I repeat, these lifestyle changes, although we say them all the time, believe it or not, I think the generation, the young generation right now will benefit probably the most, because it's being worked into their lives at a societal level, from school, from commercials, from everything. So they're starting now. They're starting when they're young. There's still room for all of us to have a good impact on this, but over time, hopefully, I'm seeing that this will help impact cancers and that they will go down over time. Okay. So I've beaten that one up to death. Sorry. Not meaning to preach, just meaning to try and educate. So again, the emphasis on this is lifestyle, 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 choices, choices, choices. I want you to know that each one of the choices you make when you bring that fork to your mouth, okay, or when you decide to get up off that couch, is going to either bring you closer to cancer or further away from cancer. Okay, so just think about it. Just put it into your awareness. And half of this battle is just being mindful. You'll see that's the new buzz term in the community, mindfulness. It's just being aware, because sometimes if you think about it, you may not do anything about it today. Tomorrow you may not do anything about it either. But the third time you think about it, guess what? You're going to park your car a little further away and you're going to walk a little further, and it's going to help. Okay, the other things in lifestyle, other than activity and diet, that help decrease your risk for cancer: no tobacco. Tobacco is a bad thing across the board. Increases your risk for cancer, particularly even breast cancer. Okay, I know people think about tobacco as related to lung cancer. Okay, believe it or not, nobody thinks about tobacco as related to breast cancer. Okay, but it increases your risk significantly for breast cancer as well. And alcohol is the other one that increases your risk for breast cancer. No more than 1 drink per day. Okay, women, you don't have to cut off alcohol together, but no more than 1 drink per day. Okay, so in closing, these are just some thoughts. I just want you to take home messages here. American Cancer Society statistics show that Black females who get breast cancer are 40% more likely to die from the disease than non-Black females. Okay, and Black females between the ages of 40 and 50 have a 100%, they've double the risk of dying than their non-Black counterparts. Black females get a more aggressive form of breast cancer called triple negative breast cancer, and they also get more inflammatory breast cancer. That's also an aggressive triple negative subtype. Regular mammograms, that means every year, don't stop, okay? Starting age 40, it reduces a woman's risk of dying from breast cancer by 60% within 10 years, okay? And I just want to give a little plug for Steeplechase's new high-risk program. We have a high-risk screening program. And high risk is another topic, which if you're interested in, we can go into another talk. I can't really do justice today, but we'd like to identify women who are at higher risk than the average female for getting breast cancer, and help you, with strategies that you can deal with your risk to bring down your risk, as also treat your risk and what to do about it. Okay, so we have a new high-risk screening program here at Steeplechase, and if you're interested at all, Serena can give you some additional details on her all, okay? And just let us know. Whenever you can, participate in clinical trials, because clinical trials help us find out information that can help other women as well as yourself, okay? So this is the Steeplechase Cancer Center. I just want to let you guys know that we are here 7 days a week, so to help anybody who wants any information on anything we've done. Remember that information empowers you, okay? It's not something that should cause fear. It empowers you to go out there in your life and make wise choices with everything that you do, from getting screening mammograms to eating or to walking, okay? At this point, Attiyyah and I will open up the panel to any questions that you might have. No restrictions, anything's game. Go ahead and ask.
So I'm going to actually, I'm going to share the results from the first poll real quick before we get
Mhm.
there, just so you could see it. I don't know if you see it, and then I'll kind of share the questions again to see how much you've learned.
Oh yeah, that's right. So you're going to post poll too, right? You want to post poll first?
Yep. So let's do that. I'm going to launch it in a second. So if you guys can answer, again, the same questions based on the presentation to gauge your knowledge. And the poll is active. Can you guys see it on your end? Yep. Okay, it's working. Okay. We have 26, we have 17 people that voted. So I'm gonna just give it a couple of more seconds and then I'll share the result. Okay. I'm gonna end the poll and then I'll share the results. And so if Dr. Lue, you wanna answer the questions that.
Okay. So according to the American Cancer Society, Black females who get breast cancer are more likely to die from their cancer than non-Black females. The answer is true. The incidence rate, which means Black females and white females get cancer at the same rate, but a Black female is 40% more likely to die from her cancer than a non-Black female. Black females get a less aggressive subtype of breast cancer more frequently than non-Black females. That is false. They get a more aggressive subtype of breast cancer than non-Black females. The triple negative variant and inflammatory breast cancer. Okay, and then the third question is, regular mammogram screening reduces a woman's risk of dying from breast cancer by 10%. The answer to that is false. Okay, it increases your risk of dying. Mammograms, that was a trick question, by the way. Mammograms decrease your risk of dying by way more than 10%. Okay, the most recent study in 2018 showed that it was as high as 60% over 10 years. Okay, so thank you for running the poll, Rob.
Absolutely. And then I'm going to close that
So
out.
if anyone has any questions, I don't know.
So we have a question as, which fruit and vegetables are recommended for daily diet? So that's more nutrition.
That's a nutrition, and I'm going to defer actually till next week. You have Karen coming up, correct? Karen Connolly.
Yeah, Karen Connolly, who is a nutritionist, and as I think she is also specializes in oncology nutrition.
Okay.
So she will definitely be on for, I believe, the 13th, if I'm not wrong. I will share the time. It's the 16th, and it'll be again at the same time. And so you can ask specific nutrition questions.
That being said, I will answer though, but definitely the ones that are antioxidant are the ones with more color. Okay. Also, though, there's specifically the there's minerals inside broccoli, okay, which is really good, and the green vegetables as well. But anything that has color has like carrots, you know, some of the peppers, red peppers and stuff, they have antioxidant effects overall. So they help all cancers and just inflammation, but particularly broccoli, kale, legumes, those are specific for breast cancer. They have actually some nutrients for breast cancer, but I'll let Karen go into some more detail about that.
Thank you. Any more questions? Feel free to just type it into the chat and I can read it out to Dr. Lue. So far, we don't have any more questions.
Anything about mammograms, any question that you have about high risk, anything, density.
Any about the high risk program? I just wanted to just add on to what Dr. Lue said. Our high risk cancer screening program, it's not something separate. It's a part of your mammogram appointment. So when you come in for the mammogram appointment, you will be given either a paper form or our tablet or iPad, and it's just a a list of questions that you can answer, which will help us determine your risk level. So it's not something separate that you would have to come to. It's a part of the mammogram appointment.
Yeah, I guess I just want to reform that. Remember that graph I showed you about the risk factors? Let me see, maybe I can go back here and show them. Oh, here it is. This screen. Whoa, I ended up losing that screen. Sorry, just bear with me when I just want to get back to there. These can be in question format on the tablet. We're going to ask you, how old were you when you first started having your period? Have you ever been pregnant? How old were you when you had your first child? Those will all be asked on this tablet, like Attiyyah is saying, when you come in for your mammogram. They're being asked for a purpose because we have risk models, okay, that can help us assess your risk, taking into account some of your controllable and uncontrollable risk factors. We'll have your height and weight. All of that, it goes into calculating out what your risk is for breast cancer. And if you are calculated out as being a high risk, and some of it has to do with the density of your breast, which will be calculated from your mammogram that you have done on that day as well, you'll be notified, just so you're aware of what your risk is. And if you actually fall into a high risk category, you'll be given the option, if you want, okay, to come and talk to us about it some more. What can you do about it? It's another form of education and empowerment, and that's our goal. A lot of times women, you know, if a woman gets breast cancer and she's 48 and she has high risk and she comes with her cancer from the first time after she's had cancer, and she never realized her whole life that she did have a higher risk, you know, what could she have done about it earlier? Or could she have known and done anything to prevent that from happening? Possibly, maybe, but you won't know unless you know. You don't know what you don't know, right? So this tool is just meant to help you. And this program that we're running at Steeplechase is meant to empower and help all women. Your density will be listed on your mammogram as well. Your mammogram report will actually have that density, where is that? Yeah, that density, you know, that density amount. You'll be told that you have fatty breast density, scattered breast density, heterogeneous breast density, or extremely dense breast. You have to look for those exact words on your actual mammogram: heterogeneous, extremely dense, scattered. They will show up on your actual mammogram report. Or extremely dense, that will go into calculating out your risk. I'm sorry, I didn't mean to interrupt you, Attiyyah.
Oh, no, it's okay, Dr. Lue, not at all.
Go ahead.
I'll just add to that, definitely, like Dr. Lue just said, one of the great things about having the mammogram done here at Steeplechase, we have a wonderful multidisciplinary team here. So our surgeons, I'm here in the breast center. We have our advanced practitioner nurses. We have a wonderful, you know, multidisciplinary team here, all, you know, for your care as our patient.
There aren't any additional questions in the chat. So what I'm going to do is I'm going to just launch the last poll, which is just the presentation evaluation, just so it helps us, you know, get some feedback. I'm going to go ahead and launch it. So if you can please answer these 5 questions, we would really appreciate it. So we have 20 people. Just gonna give it a couple more seconds. Okay. All right. I have one comment in the chat that says, I've heard mixed opinions regarding mammograms, that too many mammos increase risk of cancer too. Dr. Lue, I don't know if you had a comment regarding that.
Yeah. Okay. So we measure how much radiation. I assume that has to do with radiation effects. So radiation, what is the radiation on a mammogram? You get, each mammogram is about 2.5 millisieverts. What the heck does that mean? Okay, a millisievert is how we rate damage from radiation. So to give you some perspective, if you live in New York City, the background radiation from living in New York City for 1 year is about 5 millisieverts. Okay, a transatlantic flight is about 3 millisieverts. Okay, so mammogram is in about the same rate as a transatlantic flight. So certainly even 4 or 5 mammograms a year is not going to give you an excessive amount of radiation in terms of damage. A CAT scan is about 25 millisieverts, I believe, one CAT scan. So, you know, you get to give a perspective, a mammogram is about 2.5 millisieverts. It's very little, you know, in terms of radiation. Is it radiation? It is, but you'd have to have a lot of mammograms to have that effect. Not just that, radiation is a cumulative dosage, so it's over your lifetime. So that's why, for example, we do not use mammograms on women under 30 years of age for 2 reasons. First of all, they're young, and so the cumulative dose of radiation from the mammogram actually will impact them in their life, and the studies have shown this. Plus, they're more frequently young women in their 20s have very dense breasts, okay? So the mammogram is the least useful to us during that time period. Women in their 20s who need imaging, we more frequently use breast MRI, okay, which is not radiation. It's based on a totally different science using magnetic polarity of your cells to give us an image. So yes, radiation, that's a good question. Radiation does affect a person's body. The amount from a mammogram, anyone who's over 30 is not sufficiently significant to really make a difference.
That's it. I don't have any more questions. I don't see any more comments.
That's versus the value of what the mammogram's giving us. I guess what we're saying, you know.
So it says thank you. All right. So I just wanted to share the evaluation poll as well. I wanted to really just go down to the last question. As a result of this program, I intend to get a regular mammogram screening. We have people that said they'll exercise more. We did have a lot of people say eat healthier.
Woohoo!
So be sure to definitely tune in next week on Karen. She's a wonderful presenter as well. She's a wealth of knowledge when it comes to nutrition as well.
Yeah, you guys are all going to love Karen. She also, before COVID, we used to have cooking classes at Steeplechase run by Karen, and they were like standing room only and backup wait lists. Yeah, she's wonderful. You're going to love her. So if you've got any questions at all about nutrition, how it relates to cancer, how it relates to inflammation, come back for Karen, please.
Okay, sounds good. So thank you all so much. Thank you, Dr. Lue, for taking the time out and coming, presenting for us. We appreciate it so much. And everyone else, thank you so much for joining. I'm going to go ahead and end the meeting and hope to see you next week. Take care.
Bye-bye.
Bye.
Bye.
Thank you. Bye-bye.
Bye.
Thank you, Dr. Lue.
Thank you. Thank you for coming.